All right. I have hit the record button so I can officially get us underway. I'm learning WebEx did one of its infamous changes to their formatting, so we're all getting used to a little bit different presentation style here, so thank you for your patience as we troubleshoot. I have the pleasure of introducing our speakers and topic today. Welcome to, not only is it the Global Health, Nutrition, and HIV Community of Practice, but it is the Faith and Development Community of Practice April practice meeting. And today we are going to be talking about engaging faith leaders for health outcomes. This is a topic that within the health community of practice, we've been doing some activities for the last, 6 or 7 months around. Of course, with our promise, we are talking about the different partners we need to achieve our promise, and faith communities and faith leaders are a critical part of our success in achieving our promise. We have 3 speakers today that are going to look at how we, as a community of practice, have been learning and reflecting on how we engage with faith leaders. Our goal today for this community of practice session is that you walk away with perhaps a new idea for how to engage faith leaders in your programming, or you think about how can I improve the way I work with faith leaders and faith communities in my health programming. I have to learn how to shift. So hopefully you're already connected audio, but I'll help with you there. You will notice that when you logged into the webinar today, that you are automatically put on mute. And that's done on purpose so that the background noise for our speakers stays to a minimum while they are presenting their slides. But while you are mute on audio, we don't want you to be silent. Please utilize this chat box that we have below the participant list. We want you to ask your questions, make comments with all of the other participants that are here in this webinar. In that, I'll be monitoring and the speakers will be monitoring that chat box so that when we get to the Q&A and discussion part of our webinar, we're going to start with the questions that are there first. So we want you to practice and get used to using that space. So if you haven't done so already, and thank you for that, I'm seeing several people already typing in the chat box. If you haven't done so already, type in who you are, which country you're coming from. And as you walked into the webinar today, what is the question on your mind about how we engage faith leaders for health and nutrition, or maybe you're wondering, just how to do this well. So what are the questions that you're already coming to the table with? That would be great to hear. Our speakers today, we've got a lovely panel. I would like to introduce my intern, Ms. Teniola Okun. She has been working with the Global Center Sustainable Health team for a good part of this year, and she's going to be presenting on the findings that she found. We wrote a community of practice survey to ask you how you have been engaging with faith leaders. What are your successes and challenges, both inside our Channels of Hope program project model, as well as outside of that project model. We have Dr. Irene from World Vision Uganda, who will be speaking on the Uganda experience of engaging faith leaders. When Teniola read through all of your technical program documents, World Vision Uganda very much highlighted faith leaders as a strategic partner in our health programming. So we'll hear about how they've been doing that. And Dalian is our technical advisor, Channels of Hope, sitting within the TSO, and she is a member of the FND community of practice. And she is going to be coming in and presenting on what are the principles of engaging faith leaders and faith communities and providing examples from the FND community's learning. So I just want to thank our speakers for being here today, and thank you to our participants for being here today. Let's make this an active chat box. Ask lots of great questions. Our speakers are looking forward to hearing them from you. And with that, Kenyola, I am going to change the role to presenter for you and start as you are ready.
Okay, thank you, Sarah.
And in this new WebEx, everybody, we have to wait just a moment for our presenters to load slides. So great, we're starting to see your slides. Thank you, Kenyola. Go ahead.
Good morning, everybody, and welcome to our webinar today. Thank you for joining us this morning. And as Sarah has previously introduced me, my name is Teniola Okun, and I've had the pleasure and the opportunity to work with Sarah and support her in global health and nutrition programs. And I'm here to give a presentation on the survey we sent out to national offices during the summer to see how our national offices, how are we as World Vision engaging faith leaders in our health and nutrition programming. So the main question was, how are we engaging faith leaders in our programming that within and beyond channels of hope, which is the project model, like how are we engaging faith leaders in our health and nutrition programming? So in the summer, we sent out surveys to almost 100 national offices, and we had 88 responses, which showed a good representation of what our national, we showed a good representation of our national offices' responses. And we asked the question: are you engaging faith leaders in your health and nutrition programming? And most countries responded that they are engaging faith leaders in their health and nutrition programming. So we asked, what are your reasons for engaging faith leaders, and what are your reasons for not engaging faith leaders? And national offices expressed that faith leaders are very integral in influencing behavioral change because they serve as this agent of change to influence behaviors, to address myths, to address cultures, and to address norms, and also to provide awareness about a specific health issues. And why are some countries not engaging faith leaders? It depends on on the country's context. For example, the culture or the faith, as we see in Nepal and South Sudan, or it depends on not having staff to take up that responsibility. So, wanted to know, what is the root cause analysis behind engaging faith leaders in your health and nutrition programming? And most national offices express that faith leaders are very effective in influencing that behavioral change. They're very effective in helping to promote better health outcomes in children, most especially most vulnerable children. And speaking from a personal perspective, as an African Nigerian, we put our faith leaders on this high pedestal. We have regard, we have like a reference for what they say and how they encourage and advise us. So I can really relate with how faith leaders have been seen to be effective in promoting that behavioral change, in influencing decision makings, and also increasing better health outcomes. And national offices also expressed that the most prioritized health issues for faith leaders' engagement was malnutrition, which is very interesting. So, wanting to know, how often are you meeting with your faith leaders? How often are you being engaged with your faith leaders? And most countries express that they're engaged with their faith leaders monthly, while the list was weekly. We also wanted to ask the question that about providing examples of outside the normal channels of Hope Project models. In what ways are you engaging your faith leaders? And we had a lot of examples from national offices, but some of which include For example, in India, faith leaders, and we see that faith leaders and other stakeholders are being written, have the program write them in their grant request or grant acquisitions, and also faith leaders have been engaged in multi-sectorial approaches in health and nutrition programming. For example, in Malawi, faith leaders are engaged in livelihood and food security, and also faith leaders have been engaged in our global campaign It Takes a World, where in South Sudan we see it as It Takes a Nation. Also, we see faith leaders being engaged in the sense that we as World Vision asks our faith leaders to bring our health and nutrition messages to their congregations through their sermons, through their Sunday schools, or through normal church activities in the community. Also, faith leaders are seen to take up roles as CHWs, which is community health workers or community health volunteers, and also act as counselors on or advocates in the community. So, what are the successes with faith leaders engagement? National offices shows the express that faith leaders have been very successful. Engaging faith leaders have been very successful in influencing that behavioral change, in addressing that myth, in decreasing myth that surrounds um, issues such as HIV, in promoting that awareness in the community. They've been seen to actually help promote better health outcomes in the community and in the lives of children. Challenges. What are the challenges? One um, major issue or major challenge that most national faiths expressed was controversial faith beliefs and also faith system. Example, Muslim faith versus Christian faith, being in the sense that we have different faith beliefs, and as World Vision, we have our own belief, but sometimes always it's different from the faith beliefs of other faith leaders. So it's how it's navigating that controversial faith beliefs and trying to address that, but not being coercive to influence faith leaders. So it's one of the major challenges national offices expressed, and also national officials expressed that because of lack of resources or staff and also literacy levels, it creates a challenge or barrier in engaging faith leaders in health and nutrition programming. So we move to our COH, our project model implementation. We wanted to see, okay, within Channels of Hope, how long in the last 3 years, how have you implemented Channels of Hope? Just wanted to see if they are implementing faith leaders in addition to Channels of Hope. So in the last 3 years, most countries expressed that they were implementing Channels of Hope, and we asked, okay, what are the curriculum they were using, and most countries said they were using the MNCH curriculum, which is understandable because uh, we know that Channels of Hope originated in the health and nutrition program. So it's so we asked, okay, since you've been implementing Channels of Hope, what are the successes you've seen with that? And the main thing that the countries expressed was that they see the self-efficacy among the faith leaders, where the faith leaders take that program, that project model as their own, where they are very involved in the planning, in the implementation of that program. Is we see they saw that it increased that community ownership, where they take it as their own. That at the end of World Vision's time, either in an ADP or in a community, the community members, the faith leaders actually take it on, promote health and nutrition outcomes through that Channels of Hope project. So it was really interesting to see that faith leaders have actually become self-sufficient and actually shown faith and the efficacy to take up that project and also implement that project in the community. challenges about concern with channels of hope implementation is also similar to that one we found with faith leaders. We are also working around that controversial faith beliefs, um, having lack of scale up activities, and also lack of manpower, lack of resources, and literacy level. But also that turnover rate where faith leaders are often moved from one region to another region. So it reduces that scaling of activity. So I wanted to highlight some examples just to show that this is what national offices are saying about the challenges they have with faith leaders engagement and COH implementation. And we can see from the examples that it has to do with sensitivity in some communities. It has to do with COH implementation being too expensive for certain communities, and also um, trying CH being having issue of not being a one size fits all for different programs and different health related issues. So we ask for recommendations that moving forward from our learning, and when we share this information with the working group and moving forward, would what would the recommendation be? What would to improve health and nutrition programming with faith leaders? And most countries highlighted very well that they would like to see faith leaders be part of the planning and the program design. When there's like a rollout of a program that has to do with engaging faith leaders, it would be they would like to see faith leaders being part of it, and not just having them, not just designing the program and just giving it to them, but being part of it to be able to see how it fits the community better. And also collaboration and partnership. They would like to see more partnership with different, like to see interdepartmental partnership, especially with faith and development and health and nutrition team, and also HEA department with the health and nutrition team. And lastly, they would um, like to see um, more capacity and training for faith leaders, and also helping to improve the controversial faith beliefs by educating them on how to controversial faith belief that does not become detrimental to health and nutrition outcome, especially for children and most vulnerable children. So from I had the opportunity, my own personal takeaway from this, I had the opportunity to be part of this program from the thorough um, TP review to the data analysis to sending the surveys and to writing the survey question and sending them with the support of Sarah. And I would say I've learned and I've seen how much Faith World Vision as an organization is leveraging on that important tool, which is faith leaders, especially in the African region, to promote well-being in children and to also increase awareness about certain health and nutrition issues. And I believe that's one important thing and great thing that World Vision is doing. But I think moving forward from here, it's like how do we do it better, and what can we do better? What can we learn, and how do we scale up the activities? Which is very interesting because I had the opportunity with Sarah to interview Irene, and I learned so much, and I'm glad that she's here and to share this to share our key learnings in regarding faith leaders engagement in health and nutrition programming. So and at this point I'd like to tell you thank you. This is the end of my presentation, and I'm open to questions or comments.
Thank you so much, Teniola, and we will be taking those questions and comments at the end. I'm already seeing some excellent questions coming into the chat box. And I want to say, as Zena is doing here now, let's reflect on, hold on, changing presenters. And let's reflect on some of the challenges and successes that have been presented here. The challenge of bringing these programs to scale, the challenge of just within our World Vision walls, how are we doing at ensuring that our teams are working together, HEA, faith and development, health and nutrition. So these are things let's think about and share experiences in the chat box. And yes, I'll be sharing the PowerPoint and recording soon after this call. Dr. Irene, we're so glad to have you here. I've given you the presenter ball, so go ahead and share your presentation as we, again, for those that just joined, WebEx has changed our interface. Dr. Irene, as Taniela had said, we after reviewing the survey and the TPs, we sat down with World Vision Uganda to have an interview with them about their experiences. And from that, we said, you know, please come and share your experiences and your ideas for engaging faith leaders for health outcome within World Vision. So I see your screen. I think we hear you, Dr. Irene. Start as you are ready. Thank you for being here.
Thank you, Sarah, for the opportunity for us to share our experience in Uganda. And thank you for all of us who are tuned in, just to listen in and learn. My name is Irene Nakatra, and currently I'm the Associate Director for Health, World Vision Uganda. I must say, I present this on behalf of the team from Uganda. I know some of them could be already tuned in. So if there are any additional questions, it will be great to hear them. I'll start right away. So by way of presentation, I'll just give you a quick background of what is in Uganda. I will then take you to some of the roles we've engaged the leaders on, the approaches they have chosen to use while implementing those roles, what World Vision is doing to make sure they manage effectively, some of our achievements and successes so far, and as usual, the challenges therein, and a few things that we are working on to get better. Now, as World Vision Uganda, we have a target of reaching out to 6 million children and women of reproductive age by 2020. That's the end of our 5-year strategy that started in 2015. And our current focus is on reproductive, maternal-child health, nutrition, and WASH. We have about 23 area programs that are active in health, and we also have 2 district-wide RMNCH projects, one in Busia and another in Hoima. Currently, we implement Channels of Hope in 12 of our 23 area programs, and to date, we have over 311 faith leaders and congregations actively engaged in our business. We mainly engage in MNCH and HIV/AIDS, and a little bit of nutrition, and we are scaling up all these to other things that are not necessarily related to health, but do support health, such as gender, and so on and so forth. This table just gives you an idea of how spread we are across the APs that are actively implementing. And maybe what you could note is why we've engaged several congregations and have even trained some chats. Not all of them are active. And this just speaks to how the processes go and what to expect of them. Now, that's not to say the churches are not doing any work, but the chats that we have put together are not yet as active as we would expect in terms of model implementation. Sarah, what's happening?
Are you having is there an issue? We're seeing very well. Is it not moving forward?
You're seeing very well?
Yes.
Oh, okay, for now I'm just seeing your picture displaying.
Oh,
okay.
No, we're seeing your slides. Have your slides disappeared?
No, I was able to scroll further and that's I'm getting the issue.
Oh, uh-oh. Let me, if you want, I can take over and pull up yours like on my, let me share your slides. Let me get to your, one moment. Adventures in WebEx, everybody. 1 second. I'm taking over presenter. And give me 1 second to share. All right, I believe this is your next slide. Do you see this, Dr. Irene? Irene? Uh-oh. Irene, I've stopped hearing your voice. Uh-oh. I think we are experiencing some bandwidth challenges. Let's give it 1 more second to see if we can, if it corrects. Sometimes it just takes a minute. All right, Irene, we're having some challenges hearing you. I'm going to try calling your phone again. One moment. Thanks, everybody, for your patience.
Page on my screen.
Oh, it looks like your audio might be back. Irene, try speaking again. Do you hear me?
Okay, I can hear loud and clear. Can you hear me?
Yes, you're back. Go ahead and continue.
Okay.
I'll move your slide.
All right. So the roles of the faith leaders. Currently, what we are really engaging them in is an enabling environment for HIV prevention and service utilization. We are identifying care and support orphans and vulnerable persons in need. They are trying to link the pregnant women, breastfeeding women, and other children to the health facility services. They're also promoting sanitation and hygiene at household level. And identifying and referring cases of obstetric fistula, especially for the case of the Hoima project. And the approaches they are using
Oh, uh-oh. Okay. We have lost you again, Irene. Let me try your phone. Let's see if we can get you via phone. Sorry, everybody. Thank you. 1 moment. I know, lost once more. I will troubleshoot. I'm putting in the phone number right now as quick as I can. Uh-oh, that's not working. All right. How about Darlene, since we've lost Irene's audio, oh wait, hold on. Irene?
Hello?
Oh, we hear you now. Sorry, we keep,
Okay,
there we go.
Someone is muting my phone. Please make sure you don't mute my microphone.
Okay, sorry about that. All right, here we go. That's Adventures in WebEx. All right, I'm going to go ahead and share once more time. We lost your audio as you were talking about approaches used by faith leaders. Go ahead.
Okay, I'm back. So like I was saying, the commonest approach is leveraging the already existing platforms on the congregations that we know is always available to these leaders, and making sure when they're doing their thing, the sermons, the pastoral visits, the church group meetings, they begin to communicate some of our messages. And we're also making sure that at the end of each service, mass, name it, at least there are a few messages they can routinely share with our congregation. They've been engaged in community sensitization, and they've taken it upon themselves to think of the various channels they can use, including music and drama during the community gatherings and meetings. And we've seen a number of them forming groups whose specific mission is just to bring hope to the vulnerable people. So when you go to districts like Boyikwe, you will find a group that is dedicated just to doing that and have a clear mission on stigma and discrimination, as well as GBV. They do a lot of home visits, but specifically for the case of Boyikwe, we have seen them focusing on newborns, especially after baptism. Once they identify those children, especially the Catholic Church, where they bring in the children very early, then they take it upon themselves to have a follow-on appointment where they just discuss issues surrounding newborn care and also nutrition for the mother. And then we also see them engaging in a very special way with the GB survivors and the most vulnerable mothers. We see that our chats, because we do support in the selection of chats, we see a number of them composed of health personnel, and these also help them in planning for their health activities like outreaches, which we think is a great idea. The community gatherings, the parties, burials, weddings, when a faith leader is there again, they are encouraged. Usually they'll be given the opportunity to speak, and we get them to talk about the health messages. Now, in one of our areas, we've actually seen the faith leaders forming an association. And as usual, most of these associations will find something that glues them. And a quick one was Saving for Transformation, and we have supported them in that, and we see that grow. And in there, of course, they're able to support the mothers who need additional care, either by getting them aboard or even having the resources to support them without necessarily getting into their own pockets. And then we've also seen the congregations reaching out actively to the youth with HIV life skills. And as they keep building this up, getting their peers and all that, we see them scheduling weekly meetings and learning sessions where the youth peers begin to support others. How does that get to happen? It's because World Vision is in the background, trying to make sure they are comfortable to do what they do and continuously exchanging on how it gets better. So like I mentioned, we have 311 faith leaders. All these have been trained in the channels of hope for respective things. Some in MNCH, some gender-based violence, some child protection, WASH, and each one of them is playing their part as per the training they went through. We continuously follow them up and mentor them because we know some things are not clear by the end of the training. We've also gotten some youth leaders within the church as key trainees to support their peers outside there. And then we support the youth specifically to reach out to their youth by way of sensitization, and especially at household level. Currently, World Vision is rolling out a concept on households coming under a cluster, about 25 to 30 of them. So the youth from the churches then are along the cluster model, go ahead and sensitize their peers. We support them, hold quarterly reflection meetings where they just chat about what's happening, what needs to be improved, what more needs to be done, and that kind of thing, even as they do. So here we may be present, we may not be present, but we really encourage them meeting often so that they remain alive. And then we do have some facilitation for them to do their follow-up even by themselves. And not to mention the logistics that are required, things like books, files, pens, those tiny things that they need to put it together and to be able to record and report back to us. Now that's a picture in one of the mosques with one of our chats supporting the team and engaging with some of the things within the congregation over there. So what are some of our successes we will talk about? Largely, we see the congregations appreciating what more they can do as regards to maternal health, because originally we thought maybe it's the health facility that's supposed to take that one and probably they'll just stop at referring. But they now realize there is more they can do and they are happy to do it. As we speak, just in Uyikwe, we've seen 287 pregnant mothers reached by these messages, specifically from that setting. And I must mention this figure is probably lower than is, again, because we are having some documentation challenges, as I will speak to a little later. For the case of Kamwenge, and this might be just one case, but for us it's a real success story. We saw a mother who had delivered 3 of their children at home, but through the efforts of the faith leaders, we actually got this mother to deliver at a health facility for the first time. Now, these are the real cases that we need these leaders to reach out to, where we have failed with the other channels. We've seen them supporting up to 232 breastfeeding mothers with good nutrition practices, supporting them to seek immunization, and even seeking care for their children in time. We are seeing them reporting actively on maternal and child deaths. So far, just in Buyikwe, we've had them proactively coming over, speaking to the children that are lost, rather that have just died, and the mothers. And this already gets us in motion on what could have happened and what could be done better. So if we get them to report this, they'll actually support us in the maternal and perinatal death audit that we are currently working on broadly. And then to show that they're actually that interested, we've seen some congregations opening up their premises for the interventions. So we now get to see health workers camping at the premises, maybe after the church and all that, to conduct their regular outreach interventions. We're also now seeing congregations openly supporting vulnerable people, and especially those with HIV, with prevention and treatment messages. This, the congregations have taken on by themselves. They are reaching out to the people through the drama, and as we speak, about 1,400 community members have just been reached by our congregations. We know that retention in care is still a problem for the HIV program, and we're already seeing them, supporting them, doing additional counseling where need be. And again, in Uyikwe, we saw 67 people living with HIV returned to care, and yet they had been previously lost. We have seen drama groups. So while the church is also doing their drama groups, but they're also supporting the teams out there to form drama groups by themselves so that they can continuously share, but also be able to continuously sensitize the populace. It is important to mention that even the faith leaders themselves might have attitude issues towards some of the challenges like HIV. In the case of Uyikwe, some actually perceived it as kind of a penalty for evil. And us engaging with them regularly, we have seen this attitude change, and this is evidenced by now how they're supporting the vulnerable people, they themselves reaching out with the messages, them involving the people living with HIV in their leadership. As we see 20 congregations have at least one person. We see interventions in the mosques and churches, also focusing on these people, trying to support them, looking out for the widows. And currently 194 vulnerable children and 134 widows are being supported by the churches directly in Uyekwe. We also see several community members and households being reached with by the church leaders, specifically talking about the issues of gender-based violence, and also supporting women to come out so that all these dangers that could arise just because of violence are mitigated. And we also see them getting into initiatives that are originally thought of as just the duty of the facilities and health system, but now they're supporting those initiatives. We have seen a chart specifically going to a health facility and coming up with a demonstration garden, and they're taking it upon themselves, not a health worker, but she herself making sure as mothers come in, she's supporting them to see how this is done, and we see them cascading this down to their households. And like I mentioned earlier on, for Kasitu, we have the Congregational Union, who is now doing savings and also supporting others to think in the same direction. Finally, we see youth being attracted to churches and participating more in congregation activities. Their behavior seems to be changing, progressive. It's not something I can speak to with numbers, but those that are interacting with masses of the youth in Uyekwe can attest to that. We see them working to work together, and they are forming groups here and there, and teamwork is being exhibited. But even as they participate in these groups, we see them going away from these other behaviors that would have engaged them otherwise. We see them going to test more, at least no more. They fear for HIV and we're not testing, already then supports them towards behavior change, but also seeking care where need be. And of course, as a result, a number of them have acquired some skills, including life skills like income generating activities. This slide just speaks about the data that we saw in regard to elimination of gender-based violence in communities of Uyekwe. By 2015, as we were starting, we had only 54% of the population feeling that the faith leaders were doing something in relation to GBV. And as of 2018, close to 78 thought they were actively engaged. So if the communities think so, who are we to think otherwise? Now, what are the challenges that we have been facing even as we've been implementing? One, we realize that as a program, we do implement several models, and all of them have a few things we're looking at here and there, and perhaps those are the priorities of the program. Now, what happens even as we do channels of hope, we begin to gravitate towards the same. And so you begin to see a case where the channels of hope member is looking at what the VHT and the TTC is looking at. And then you begin wondering if we are not duplicating instead of focusing for the different things. And for that, we are trying to see how we set up an agenda where we prioritize the things that we think the faith leaders should be addressing, and then they can leave the general ones at the other side. Not a very simple task, but we are up to it. We've had issues of supervision. Of course, the church tends to be more, and it is the same team that is supporting all these other models that's also supposed to be supporting these leaders. So somewhere, somehow, we fall short of supervision, and it might explain why the data we have for now is not complete. But we are aware of that, and we're trying to think through how we can get this to move. We have been doing a lot of training, the capacity building, like I mentioned earlier, and we've faced cases where you bring in trainings, and the people who are supposed to participate as trainers of trainers seem to be totally off. And we thought probably the criteria wasn't very clear, or by default, some of the leaders who should be influential just don't meet the criteria we thought was. So we have since thought through putting up a criteria that will give us the right people, not necessarily emulating the others, but making sure the ones who are supposed to cascade this are at least the right people with the skill to take us there. Data collection has been a problem, especially because we do not have any standardized monitoring tools. So even putting it and aggregating it together is a problem. But we have since agreed, once the framework of COAT engagement and the M&E framework is out, we should be able to sort this issue out. And currently, that is what our faith and development team is working on. The cost of training and making sure these charts are active is reasonably high, and that's why you see us going a little slow. Those numbers that I presented on the third slide were rather small, but we have chosen to go slowly because it's a bit costly, and we hope as we learn, we'll also be thinking through even more cost-efficient ways of getting there. We see minimal commitment for some of the congregations despite the training. And we are thinking, and of course, this comes with financial expectations, which we are not so interested in doing because we would rather they work within what is already existent. But it doesn't stop them from expecting that and their motivation being low. However, we have decided we will be engaging at a slightly higher level. Instead of going down to the churches, probably at the district, we might want to start from the region. We are already trying to see how we engage the bureaus, the Interreligious Council, and trying to establish an MOU, just discussing how we can work together towards this. It made a little bit of a hitch here because of family planning and all that, but at least we on the way. We have also decided to encourage the faith leaders to come in. Each time we engage, they come with some report of sorts, and we hope as the M&E framework comes out, the tools will be simple enough for them to come with some data so that we are able to aggregate some data and use it at a larger level to inform programming. So that's a picture of one of the dialogue meetings we're having, again, talking about the issues and seeing what the faith leaders can take on. We see an engaged team, and we are happy to continue engaging with them regularly. That's another picture of the same meeting, with people happy to have been part of a meeting, and we are yet to see how they are functioning after that engagement. So I'll stop there for now and welcome any clarification or anything that you can also add to us even as we go away. I thank you for listening.
Thank you, Irene. And we do have questions coming in the chat box, and we're going to do our full Q&A after Dalian's presentation. But as I'm switching presentations, I want to ask you one of the questions that's come in. There's a question a few people have about so we have several faith-based organizations that work within Uganda and throughout the world. What do you see as World Vision's uniqueness in how we work with faith leaders? Is there something that stands out to you that holds World Vision's faith engagement a little different or more unique?
Absolutely, Sarah. Now, slightly different, and again, I speak a little bit of authority on this because I've been elsewhere where indeed we're engaging faith leaders, but was a bit too superficial, and we actually hear the complaint. Again, similar to what Teniola was presenting. The faith leaders felt like were only called on at a time for something. The information go and do. They were not engaged in the planning. They do not develop the plan on what they want to take on. So the agenda is pretty much set, and they're expected to just comply. Now, with the way we are doing it, and especially during the training, People are expected to generate plans. Their ideas are embedded in the plan, and when they go out, in essence, they're implementing their own plans, not necessarily our plans. And that's a little bit fulfilling. Not across, again, because of the expectation of remuneration for the service, which we want to desist from, but for those that have really appreciated how much more they can offer within their calling, we really see them as grateful that we are doing it this way.
Thank you for answering that first question, and there will be more at the end of Dalian's presentation. So everyone, thank you for the questions coming in the chat box. Please don't let our panel's expertise and insights slip away from you. Please utilize this opportunity to ask them your questions, and we will dive into those questions after this next presentation. Dalian, I have your slides up, and Dalian is coming to present after leading a focus group in Lesotho. So from the field herself, start as you are ready, and I will do my best to keep up with you, my friend.
Thank you, Sarah. Hello, everybody. It's really my privilege to share with you our World Vision principles of faith community engagement specifically for the health community. And I'm going to not only talk about channels of hope. So you can go to the next slide another one. Thank you. So we know that World Vision's reach and our integrity is really worldwide. Most people identify with a specific faith group. Next slide. We also know that in communities, very often these faith leaders can be a blockage to specifically health interventions. Very often because they are not sure of the messages that we bring, and specifically in HEA situations where we come in with hazmat suits and masks and gloves, it can be very scary. A study was done by Caritas, and they really, what was for me very beautiful, and that's why I've put the quote here for you. It is really come to the fore in recent years from multiple international donors that faith communities are ideally placed to play an extremely important role. In addition to that, our strategy specifically say that we identify churches as our preferred partner. So if us as an organization say churches and faith communities and faith actors is our preferred partners, and the bigger development world out there say that faith leaders have an important role to play, then we need to learn from what are we doing, what works and what don't work well. So next slide. I'm going to focus only specific on a couple of examples from West Africa and South Pacific region because they have different faith contexts. In West Africa, it's primarily a Muslim context. And in countries like India, it is Hindu, Taiwan is Buddhist communities. So it is really multiple faith contexts where we have some wonderful examples of work. Now, over and above the examples that Teniola has mentioned, I want to start by our best faith example that have given the most international credibility to World Vision, and that was the Ebola response of 2014 in Sierra Leone. And I'm going to say something about the current one in DRC in a minute. But our biggest success in the international community was specifically how we implemented emergency response. And what was key about what worked in Sierra Leone was specifically that the faith leaders took action and that they took ownership of the whole thing. Now, a lot of both Teniola and Dr. Irene have talked about Channels of Hope. We have 5 current curriculums for Channels of Hope. And I just quickly want to say something about that. All 5 of them use the same theory of change. They use the same basic principles. And you will choose, or you will select which one of the 5 you use based on your community assessment that you do. So it forms part of our LEAP process. So the key lessons about faith engagement by a Johns Hopkins study that they have identified World Vision's Channels of Hope as one of the programs that they investigated was that say it's all about trust and putting people first. You need to build on lessons from previous epidemics, and that international faith-based organizations like World Vision, and we were named by our name, we were specifically highlighted, with our existing relationships have a unique role and an important role. So next, in our experience, we had, for example, from 2005 to 2004, we had more than 400,000 faith leaders attended some kind of Channels of Hope workshop. And we, you can, sorry, Sarah, you can stay with the slide where you are now. This is just additional statistics that I have.
Sorry, Dahlia.
No problem. And we currently, according to Horizon, works with 57,500 faithful local communities through our existing work. So there is a huge potential for us to specifically look at how can we best capitalize on what we are doing. We found, for example, in the Moment Grant in Kenya, that facility delivery have increased with more than 70% in one community within 3 months after they implemented specific interventions with the faith leaders. So the results is there. It is now about what is the key lesson. So next slide, please. Sarah, you need to be with the slide that says key lessons, right? Next one. So what was the key lesson? Firstly, we need to have existing relationships, and communities trust faith-based organizations more. We need to understand the faith-related issues in that community. So when we do our LEAP process, when we do our community assessment, we need to look deeper than just people in this community don't go and pick water at the new well. Why? Because there's in the city we just now found a specific borehole that was made by World Vision. There's nothing wrong with the water. The water was tested, but there's I don't know, what do you call a group of cats, a community of cats, a school of cats, whatever. And there's a group of feral cats that have a nest close to the borehole, and the majority of the cats is black. And because of the local customs and beliefs, they believe that therefore the water is not safe to use because there's black cats drinking the water. So if we do our assessment and we don't get to the underlying reasons why people don't use certain services, then we miss an important opportunity. We need to speak the faith language that relate to the local faith leaders and faith communities. In the Ebola response, for example, in Sierra Leone, burial practices was extremely important. It was important that the faith leaders are forming part of the preparing of the body for the burial. In that specific custom, when Ebola happened, CDC came in and everybody with our hazmat suits, we took the bodies away. And we did not allow the faith leader to be part of that washing and preparing for the burial, which made the community hide the sick and the dead. So that just escalated the problem. You need to have existing programmings, and we need to use our existing program approaches to catalyze faith communities for a comprehensive approach. So yes, the faith community needs to be part and parcel of everything that we do. We find that our result uptake is faster if the messaging and behavior, we mobilize it according to appropriate care and protection of the most vulnerable. Because faith leaders by nature, they want to make sure that by nature, they care for the most vulnerable in their communities. So our messaging of most vulnerable is in line with what they also see. So next slide. Way forward. Is that where we are now? Right. What we need to do is we need to first remember that we should not do harm. Now, in health, there's a saying that half a dose is as dangerous as no dose. You all know the principle. If I'm going to take antibiotics, I need to take the full course and I need to do it correctly. So when we work with faith leaders, we need to make sure that the messages needs to be specifically linked to value-based guiding principles that enable them to internalize our messages within their faith. So therefore, if I want to work with a Muslim community, I need to understand what will be the value-based for them. We need to give them full and complete information. We need to bridge the secular, scientific, biomedical, technical gap with faith dimensions. They want to know the essential information, and by giving them the essential information, we are able to bring about behavioral change and we combat resistance. We need to provide them, the second principle is there needs to be a safe space. If we provide a safe space for them to interact with religious texts, to discover, frame and embrace their response, they are more open to work with us. And lastly, we need to be faith specific. We need to go beyond the faith leader to include leaders from the local congregations or the yamas or the in the Buddhist community, for example, we found that if we actually go down to the community now, I don't know how many of you know that Buddhism, for example, is actually not an official faith. Yet, when we work with them, we need to understand what is their local cultural beliefs and practices so that we can frame our messaging specifically for that context. Next slide. We have, as World Vision, and I will make sure that we give you the link to World Vision Central, we have a partnership framework for engaging different faith communities for children well-being. And it's framed under four big headings. You should be by slide 13 now, yeah. The first is about our vision for other faith partnerships, the principles and guidelines for other faith community partnerships, how to develop the partnership, and sharing best practices. And I just want to spend a couple of minutes with this slide. So what is our vision for other faith partnerships? As Christians, we believe God created all humans according to His image and His goodness. He works through people of faith. So we as World Vision are called to work with any person, community or organization through which God can pursue His plan, as we recognize that God can use everyone as His agent of change. That's a tough one. I'm going to repeat a couple of key things. We work with any person, community or organization. We believe that God can use everyone as His agent of change. Even the Muslim imam, even the Hindu priest, everyone. So we are mission-driven regardless of communities' faiths. We embrace the opportunity to bridge building amongst people of different faiths and cultures. And we adhere to our affirmation of Christian witness in multi and or other faith contexts. Now, for me to be able to do that, firstly, I need to be secure and comfortable in my own faith. And that is where we find very often in countries where people need additional help. Because what happens is if I have fear about talking to somebody from a different faith, that fear will translate to resistance, and it will be difficult for me to engage and form partnerships. So the next thing is then principles and guidelines for interfaith engagements. We say World Vision staff are confident in their own faith. We will be equipped to understand those in the community from other religious traditions, beliefs, and affiliations. We believe poverty can have spiritual and religious roots. We must address underlying spiritual and religious root causes. Faith actors from different faiths can come together around our common objective for children. This includes a wide range of child well-being objectives. We believe conversations with different faith actors focus on quality and impact of work to improve the community for children. Faith actors are often present in areas where government are distant from people, and there is 4 more, but I'm not going to read all of you, for you. I really want to encourage you to go and look it up. The next principle is then how to develop faith partnerships. So the first thing there is you need to know your context. You need to conduct a national faith mapping and landscape analysis to identify faith forums, represented denominations, and influential faith leaders. If you've done this religious analysis, then you are able to understand which is the different religious groupings that you need to work with. This landscape mapping also provides you with essential information that can help you. It helps you to know, use your global and regional networks and platforms. It helps you understand the faith diversity, and you can see what is the different theological viewpoints. For example, Islam is not only does not have one theological viewpoint. We have 2 primary groups, the Sunni and the Shia, and they are so dramatically different. They don't even like to have coffee and tea with one another. So there's many other different traditions and religious and then there's some religious groups that call themselves religious, but we as Christians see them as sects. So we need to understand what is the sacred text that they use and how does that apply to their understanding of health in the community. In Zimbabwe, for example, there's a specific religious group that believe their followers should not attend any health facility. Because traditionally, and when we started looking at the root causes for that belief, it was because in that specific community where they came from, the hospitals and the health facilities were traditionally built and set up by the Roman Catholic Church. So they were scared that if their followers will go to the clinic or the health facility, they will be converted to Roman Catholics. They call themselves a Christian faith, but they had this fear about another Christian faith that made them discourage their people to attend a health facility. Then we also need to do the local level community mapping, and we need to do the root cause analysis, which I just talked about. The slides that Sarah will share with you, you will see that this document, for example, is in the note pages as well as the references. Right. So one of the questions that I think, I can't remember who asked it, but there was a specific question about the impact. So what? So we do all this training, we do all this partnership engagement. Next slide, please. We now make sure that we follow our guideline. We make sure that we do it right. We put people first. We plan and implement with the community. We do channels of hope, empowered worldviews, spiritual nurture of children, whatever. But then, so what? What is our evidence? How do we go forward? So channels of hope by nature, what happens is it's enabling project model. So it enables the community and enable the faith leaders to openly talk about issues that deals with stigma and discrimination in their community. So it opened the door for other project models. We found that chats by their nature, and there was a question about what is chat, in the Channels of Hope process, we encourage faith communities to form congregational hope action teams. And these, you are at the right slide, yes, and these chats then go back to their communities and they start developing action plans, and they start implementing a wide variety of different things. Now, Sarah started by saying, I'm in the community busy with focus group discussions. In the current situation, we realize that we do not have a lot of impact evidence at the moment on what chats is exactly doing. So right now, we are busy with impact research in Lesotho. From here, we're going to do a second one in Zambia in next month. And then World Vision US, Lauren and her team, Gloria, they are going to do a year-long impact study with World Vision Kenya and World Vision Zimbabwe, exactly trying to answer these questions. Now, one of the key findings so far that I have found is that the chats do have records. Today's chat, one faith leader, for example, was able to tell me that after the chat was formed, they have done income generating activity training, 17 savings groups were formed in one congregation, a congregation that only has 120 members, so like in 17 groups amongst 120 people, that's massive. It's almost everybody in the congregation belong to a saving group now. But and then this chats do have records. I took photos today of some of these record books of them. So we're trying to see where's the gap. Why don't we have this information on Horizon? We follow the route to say, okay, so you do calculate, you do count. What do you do then? Where do you take it? They hand it in at the area program. The area program currently, in so far that we found, and this is now off the record. I can't really say it is everywhere because we're in the middle, and it's very preliminary to say this as findings, but currently what we see so far is that the area program calculate all of the information that they get from the chats, and they report it as one number to contribute to spiritual nurture of children, mainly. So they don't aggregate the data separately because it's such a wide variety of information that they receive. Our research questions primarily deal with HIV and gender-based violence at the moment. And the things that they are doing is they do counseling. They do referral for voluntary counseling and testing. They do follow-ups at community. So there's really great evidence. And we follow. We go to the clinic. We say, does the clinic see more? Does the police center see more reporting of rape cases, of child abuse cases? And everybody say to us, yes, but very few of them say, how many more? And so we are definitely looking at that at the moment. This is our biggest area of need, and I honestly believe that the health sector, you guys are ideally placed to help us with framing this into our horizon to say, how can we track these things? Our main aim is not to make new forms. There is enough existing tools. The indicators is already in our compendium of indicators. So it is looking at why don't we see it and what needs to change so that we can see it, not what new stuff needs to be developed. And only if we say there is nothing that is available, then we will consider new things. So next slide is all the resources that I've used for this presentation. And then the last slide is, by working with faith leaders and faith actors, we actually can make a change in communities. So let us take hands and stand together to bring that to our communities. World Vision is not doing this alone. We actively work with the communities we serve, and many of you are already partnering with this community. So let's make this work. Thank you.
Thank you so much, Dalian. And at this point, we are going to transition into our Q&A time. So, Dalian, I'll ask you the same question I asked Dr. Irene from Uganda. What sets World Vision apart when it comes to engaging with faith leaders? What is our unique identity in engaging with faith communities that sets us apart from other NGOs?
Oh, I actually started with that by saying our vision and mission specifically say that we identify churches and faith communities as our preferred partner. Firstly. Secondly, we already have, the communities already believe in us. And we already have existing trust in communities, which make that faith leaders are keen to partner with us and are willing to work with us. And that is across faith. A Muslim imam once said, it is a joy to work with World Vision because it is a joy to work with people that is as serious about their own faith as I am. So for a Muslim to say, I rather want to work with you than a Muslim organization because you take your faith serious, that's awesome. That shows that our staff is truly committed.
Thank you. Thank you very much. Now, I will continue in this time of Q&A to monitor our chat box for questions, so keep them coming there. But if you would rather ask your question verbally, go ahead and use the raise hand feature to the right of your name. My next question, and Dr. Irene, I have unmuted you because this question came during your presentation. Irene, in your presentation, you noted that there are activities being taken up by faith leaders and chats that seem to be duplicates of some of our other project models, TTC and COM. So when you're looking at what's being duplicated, can you point to what are the unique contributions of faith leaders? What is it that the faith communities are doing that is their unique role that cannot be or should not be duplicated by other project model implementers?
Wow. Sorry, make the question even bigger. But thank you for asking that because it was the question at the point when we were discussing this with the implementers. Now, for example, TTC, if I may start with that since it's what we do almost all through. We are expected to see the village health teams interacting with the households and discussing all these things with the guidance and the job aids that we provide to them. And in there, we expect them maybe now to talk about if it's infant and young child feeding, going through that whole set of things that need to be done. And at the end of the day, what we expect is that the mothers will change the behaviors, or at least will adapt what is expected. Similarly, they will go to a pregnant woman and go through exactly the same thing of we expect you to deliver in the facility. During this stage, we want you to do A, B, C, D. Now, what we were saying, that even for the chat, and specifically for the chat, let's go away from chat where we get the leaders speaking about this, sensitizing generally. But at a household level, again, we began to see chats, again, dwelling on exactly the same message. And for the case where we found the chats doubling as the VHTs, it became a little easier. But now where you have the chats the other side and the VHTs here, you would now see a case of the VHT was here speaking about this. The next day, maybe the chat member is also coming to speak more about the same thing. And so at that point, we're wondering, isn't this really duplication? Shouldn't we maybe concentrate on something different here, or if this is complementary? So that's the kind of potential duplication that we are seeing. And we're just thinking through where it may be the same thing, could there be maybe a little bit of focus on something in detail by the church leaders? We don't have an answer, but we just see that overlap here and there, and it's of concern.
Thank you. So, and Diane, I see that you are already typing in the chat box answers to the question around how do we support our faith leaders in data collection? What does that look like? Would you mind just unmuting and talk us through that a bit? Since there were a couple of questions around supervision and support and the data collection, it seems to be a gap. So how do we support our faith leaders in this effort?
Well, the short answer to that is I don't know the answer yet. I need to put on my research hat for that. That's exactly what we're trying to see now. That's exactly what this research is about. And even though I have some ideas, I would prefer not to respond to that because we really want to see what is it that we find now. We will be doing it in 4 countries. We are using the same tools in all 4 countries to really find what is wrong. There is tools available. Theoretically, if people use the tools, we should have the information. So we are trying to find out, are they not using the tools? Is the tools not correct? And so on. But yes, what we find the main way in which faith leaders currently collect data is they either use the chat form 4, which is available on World Vision Central. It's open source. Anybody can download it. It's a one-pager. It's very simple and quick for them to fill in. Or in some APs, the AP provide them with a normal notebook with lines, and then they keep records of their minutes and their attendance. Currently, the majority of the faith leaders actually collect numbers reach, how many, they're very activity-based. And when we ask them impact questions, they are able to tell us, but they currently don't include that in their monthly reports to the AP. So that is one of the gaps that we already can see, and I think that is a cultural change we need to do, probably, to say, do we just ask people about how many people have eaten food, or do we say, so what after that they come into school, what happened there? The other question, there was a question from Adunia on what else are we doing to promote health-seeking behavior, especially for patients to seek treatment early and adhere to treatment. That is one of the key functions of a chat, to promote voluntary counseling and testing, to refer people to the clinic, and to have and Dr. Irene had quite a number of really good examples of the kind of things that chats will do, drama groups, like community outreach, on health-seeking behaviors, identifying danger signs, and those kinds of healthy behavior practices. What we find so far is that we need to link it with implementation of comms or time and targeted counseling. You must always remember channels of focus are enabling environment. And now normal programming needs to follow. Because one of the things that happens is the chat becomes really excited, and then there's an increased need there's an increase in clinic referrals, but the facility is not ready to take on this new referrals that's coming. So if comms is not going hand in hand with this implementation and mobilizing of your faith leaders, then immediately there is a disconnect in service delivering at the community level.
Thank you, Darian. Irene, I'll come back to you. There were questions in the chat box around what is your tactics for supervision and mentorship?
And mentoring, yeah.
Yeah, so what is your advice to offices when it comes to what you've learned around supervision and mentoring?
The one thing we've learned, if it doesn't happen, you will not get any result. You will train, for example, And then when you go back 3 months, 4 months, you actually not have any active chat. And it's like you never ever trained. Now, what we are working on and what we think might give us some results, and probably was a gap as we started, was getting the right team of the T or Ts, because ultimately these trainers of trainers are also supposed to be our mentors routinely. And then having a clear schedule of how in month 1 you should have visit, interact, and see how this is working. Now, while we trained and we thought the TOTs would work, we laid back. And I guess that's where it kind of went a bit wrong, and why we see 0 in some cases where we even did the trainings with the congregation. So we have just decided that for us, we will have a simple tool which speaks to what we want them to focus on even as they interact with these trainees. And then also beginning to think through what they should be seeing as their key outputs, even as they engage on that. We think once they have something they're looking at as end in mind, then they will be able to progressively review their own performance. So in terms of the mentorship, it's mainly the kind of schedule we want to see, knowing that just training and going back at the end of the quarter to see what's happening will not get us results. So we are putting together a schedule of after training, 2 weeks later, just go have a brief chat, feeling how it's been. Then a month later, go back again and see what outputs they're beginning to see and how confident they're getting, thinking through the quality of the message that's going out there and all that. And then maybe we begin to win them off after the 3rd visit, where we become a little less regular and mainly interact during the reflection meetings as they come together, as they share what they are seeing, as they use the reporting tools and the data collection tools that we want to put in place. That's what we see as something that will help us in the mentorship. Now, that's not very little work, considering the team that's out also is supposed to supervise the trainers of trainers, because the team is also supposed to be seeing the quality of what the trainers are doing out there for us to be sure that all is well.
Thank you. Friends, I see that we are coming to the end of our time. So at this moment, I'm going to take this opportunity to say thank you very much to our all-African panel, Teniola, Irene, and Dalian.
You're welcome, Sarah.
Thank you so much for sharing your research, your experiences, and your advice with this community of practice. And for those who have been with us in our participant list, thank you for being active listeners and in the chat box. We do not want this conversation to be the end. We have spaces for you to come on WV Central and on WVI.org to continue to look for the different resources. You can visit the Health Community of Practice page, Faith and Development Community of Practice page when you're looking for reports, evidence, connecting with leaders like Dalian, Irene, Teniola. You will find them in these spaces. You can also continue to ask your questions. If you're looking for information about Channels of Hope and Help work that you can share with peers and partners, please use our WVI.org spaces to do that. And just a few announcements about next and coming up. I'll share the screen. World Vision Month is coming up in May. The Faith and Development Community of Practice newsletter. Be checking your inbox to read that news. And on April 30th, there is another webinar from SND. So look at your calendars. Within health, just a reminder that we are gearing up towards our Women Deliver engagement. And stay tuned for new learnings and resources that are being put together so we can talk about ending child marriage, community health workers in fragile contexts, faith leaders' role in reproductive health, and nutrition through the lens of gender. And there is also an open call for abstracts for the second Community Health Worker Symposium. Information about both of these events can be found on the Health Community of Practice page. So with that, I just want to say once again, thank you so much for participating. The notes and recording and links that have been shared in the chat box will be shared with you via email in the next day. And thank you for your participation. We'll see you on the next WebEx. Bye, everybody.
Bye-bye.
Bye.
Thank you so much.
Thank you. Have a good rest of your day.